start this meeting, series of the meetings with our SIG, PCBH SIG, presenting today about geriatric primary care. Now, I don't know what to expect. Does anybody know how long this meeting is supposed to go, this presentation?
Yeah, Alex, I don't think there's a hard and fast requirement. I think we have like the hour kind of slotted, but we'll make the most of the time.
Okay. Corey, thank you so much for your input. So you guys, I am having to presenting today and very proud and very excited for this presentation. Geriatric primary care is geriatric primary care and behavioral health is my passion. So I am going to start our conversation today. And here's what I'm going to say. If you are, because there's not too many of us, I keep clicking to see how many people are here, not too many of us. So if you guys have comment or question, please go ahead and ask. You don't have to wait until the end of the presentation. Just let's have a conversation rather than strict presentation. Is that okay with everybody? All right. So I'm going to start with this. I need to share my screen, right? Okay, let me see. Okay. Do you guys see my screen? Yes.
Yes.
Wonderful. Okay. Fine. So today's presentation is brought to you by PCBH SIG, and I'm one of the co-chairs for PCBH SIG, and I'm working in San Diego at UCSD Health. I'm working at primary care clinic, both internal medicine and geriatric primary care clinic. And my presentation today is related, obviously, to geriatric primary care clinic, and my colleagues work within geriatric primary care clinic with behavioral health input. So why do we have to talk about geriatric primary care and behavioral health? Well, I think it's not a secret that in geriatric population, certain behavioral health conditions are frequently underdetected because they are not talked about, and also intertwined with other chronic conditions which mask the behavioral health issues. I will bring you some of the statistics, such as about 10-15% of geriatric primary care patients do have a depressive disorder, often comorbid with other disorders, and caused by their physical health conditions. 20-22% of commonly dwelling older adults, those who live in community settings, meet criteria for some mental disorder, including major neurocognitive disorder that also goes undetected. The majority of older adults with mental health problems do not go to specialty care. Like I want to see a psychologist or a psychiatrist. They come to primary care physician, and most of the time they complain about their physical issues, not mental issues. And lastly, I want to bring it up that in 2026, Substance Abuse and Mental Health Services Administration, along with some other trials that support this as well, issued a statement that strongly supports integrating behavioral health into primary care through team-based collaborative care models as evidence-based and cost-effective, both. So far, so good? You guys with me? Okay. So in working with geriatric populations, several conditions that are research supports that we need to prioritize over other conditions. First and foremost, of course, depression for various reasons. For example, depression comes with more somatic complaints in older adults rather than in complaints of sadness and grief. So it's often under-recognized. It's exacerbate depression in older adults, exacerbates their chronic diseases, physical conditions, diabetes, heart diseases, and arthritis, and vice versa. The diseases, pain problems, they exacerbate the depression symptoms as well. So when we're talking about these diseases, we have to be really careful about asking more questions and recognize sometimes depression even in older adults. Recognize, you guys remember from school that term pseudo dementia in older adults? Yeah, pseudo dementia frequently comes in geriatric population. Anxiety disorders, very common in late life, but people come and say they worry. Majority of the stuff that they worry about are coming to three things: health, finances, and fear to fall, loss of safety. Fear to fall. So generalized anxiety disorders are common to show up in older adults, even if they before have not been prone to anxiety. Hard to diagnose when they're talking about specific issues, like we say, okay, it's reasonable, yeah, you're worrying about falling. Is this an anxiety? Is this a generalized anxiety, right? So we have to be very, very careful about diagnosing anxiety disorder. Cognitive impairments, such as various dementias, very difficult to diagnose and oftentimes underdiagnosed and therefore undertreated because they mask. They don't want to everybody to know, right? Older adults. So they mask their cognitive issues with usual common sense things, and it's all very believable. They have apathy, they have withdrawal, they have sleep changes, underlying medical conditions, chronic pain. All of this contributes to each one of those disorders, in fact. Substance use, alcohol and substances misuse, overlooked in older adults. They can cause falling, they can cause cognitive impairment, they can cause mood symptoms, and oftentimes interfere with medication adherence or medication effect. And last but not least, loneliness or social isolation. These things impact everything because we know there is a variety of big body of literature talking about how loneliness contributes to depression, cognitive decline, poor health overall, and early death. Any questions about any of this so far? Okay, we're good. All right, so I put together, I found somewhere and brought it here, a schedule of risk factors versus protective factors in older adults. And I know it's difficult to read. I tried my best to magnify it so far that you guys can read it, but I printed out somewhere so I can read what it says. So risk factors include genetics, stressful life events, neuroticism, previous depression, anxiety, cardiovascular disease, insomnia, stressful life events, activity level, and cognitive impairment. Protective factors include socioeconomic advantage, high education, engagement, sense of mastery, emotion regulation ability, close social network, and meaning in life. So even having this in mind, we can always identify if there's a socioeconomic disadvantage, we can look at other risk factors, just right automatically starting doing that. Okay, the next chart is quite interesting. This chart is from JAMA Health Forum of 2026. I try to find the most recent information for you guys. And this chart reflects increased mental health services need over years from 2020 to 2024. I'm sorry, from 2000 to 2024. So 24-year period, not 4. So as you can see, let's say blue is a raw score and is it yellow or orange is adjusted score. So I'm going to go with blue, okay? So as you guys can see, depression, it started around 8 in 2000 and it ended close to 14 in 2024. Bipolar disorder, 0.6 looks like to over 1.7, 1.8 in 2024. Alcohol use disorders from around 0.9 to 1.4, above 1.4. Drug use disorders from in 2000 less than 0.5 to solid 2 points in 2024. So who knew drug use disorders increasing that much? Anxiety from about 3 maybe 4, from 4 all the way to 15 in 24 years. Schizophrenia from 0.6 decreased to close to 0.5. And tobacco use disorders increased from 2 all the way to close to 6. So what do you guys think? What is happening in here? So nobody volunteers. Okay, so what is happening is depression, anxiety, bipolar disorder, alcohol use, drug use, and tobacco use, all of these things are increasing in the last 24 years exponentially. One thing is decreasing is schizophrenia. Why would schizophrenia be decreasing when everything else, including bipolar disorder, is increasing? Well, because it's uncommon in older adults to be diagnosed as a new schizophrenia patient. Why? Because this cognitive biological developmental years when schizophrenia is first detected already over us. We're already past that, so schizophrenia is decreasing. Also, people learning how to manage the symptoms as they get older. And also they get more, those who are really honing majority of them learning how to manage medication to help with the symptoms. Okay. Screening tools for primary care visits. So anybody using PHQ-9 as an initial screen and then PHQ-2 and then PHQ-9? I think most of us know that. There is also geriatric depression scale as an alternative for anxiety, GAD-7. Anybody knows alternatives for GAD-7? Not so much. I don't know any. Okay, alcohol use and substance use. So I put in here audit as an alcohol use disorder and suggestion from Substance Use and Mental Health Services Administration to use questions about cannabis and opioids, but there is also a DUST questionnaire for substance use identification and problems with it. For cognition, there is, of course, Minicog, the MOCA, and MMSE to use. I use Minicog and MOCA very frequently. I have never had in my 12 years in primary care clinic, never have used MMSE, just never happened. Loneliness, usually recommended a simple question, how often do you feel lonely? However, UCLA has a 3-item loneliness scale that is available for everybody to use. And all of these tools are kind of leading us to age-friendly health system for EMS framework, which is what matters: medication, mentation, and mobility, where mentation encompasses depression, delirium, and dementia screening. All right, we're coming to the end very closely. So models and components with strongest evidence how to use collaboration between geriatric primary care and behavioral health. So collaborative care model, of course, brought you a result of a trial, the IMPACT trial, over 1,500 patients aged 60 and more. 45% of them achieved 50 or more % reduction in depressive symptoms at 12-month mark versus only 19% with usual care. 19% reduction, that is, with usual care. So roughly double treatment effectiveness with lower total health costs over 4 years. You can see the numbers, 29.5 roughly versus 32.5 roughly thousand per year. And that's kind of impressive. Collaborative care model rocks. Prospect is another care model that engages care management, and it's usually targeting depression and suicidal thoughts, this prospect model. PRISM E is co-located integrated health model that also has footage and has support, and it helps with behavioral health services and enhances specialty referrals. I'm sorry. Stuck. Behavioral measurement-based care is one of the components of collaborative care model, and it's frequently in research is highlighted as a core component of effective collaborative care models, and it's available for primary care physicians and behavioral health providers when we're talking about the screening tools. So in my setting, the primary care physicians are using all of the screening tools should they need to, and if they see something, they are marking me and say, can you please come in for worm handles? Practical treatment points. So usually older adults don't want to be engaged with SSRIs or any medication. They just want to do talk therapy. Research support that they prefer talk therapy to medication. However, if initial monotherapy is not effective, we can increase the effectiveness by medication plus therapy. Referral to psychiatry. When do we refer to psychiatry? We refer after if a score of PHQ-9, for example, if we're talking about depression, is remaining over 15 for 3 months or more. That's a solid reason for referral for psychiatry. And collaborative care model is supported strongly by Medicare behavioral health integration billing codes, as we all know. So that's about it for me for core presentation. I do have some common things that oftentimes discussed and asked. So for example, how do you know how many sessions will you have with this or another patient? So in the settings that I work in, I work for a department called Integrated Behavioral Health, obviously in primary care clinic, as I mentioned before, integrated internal medicine clinic and geriatric care, both clinics. And we have maximum of 12 sessions, individual clinical appointments with patients who are patients of our primary care providers. We also provide worm handle services. So in my humble experience, when I see patients who are solution focused, it's 3 to 6 appointments, 3 to 6 sessions. And those who are looking for learning for acceptance and processing things, those are more lengthy sessions and 6 to 12 sessions. I am curious about how you guys do it, so maybe somebody can comment on that. One of the most common questions that I hear from my geriatric patients, my spouse said, I'm not the person or usually the man I used to be. And they come in and saying, well, what now? I'm not the man I used to be. And oftentimes we just sit with it and ask what it means and continue processing and then focusing on what now really. Okay, you're not, but what is now? In worm handoff encounters and in individual therapy, distinguishing between suicidal thoughts and thoughts of death is extremely important. Oftentimes, when asked by primary care physicians to have suicidal thoughts and PHQ-9, they will say yes. What they mean, more than half the time, they really mean thoughts of death. They don't mean suicidal thoughts. And then question as well, if you're 85 years old, is it normal to think about death and dying versus suicide? So there is a big difference between suicide and death. So I wanted to highlight this as an option for you guys to pay attention to and think how you guys doing that and maybe sharing with each other or with me how to find and where to find a romantic partner or a friend at an advanced age. That's a big issue, comes very frequently in my practice. And of course, medication adherence. So medication adherence is big issue, oftentimes unknown by primary care provider that they're not taking, not necessarily, I'm talking about mental health medication. I mean, they won't take something of heart or GI or diabetes medication because they think something about it. They develop their perception about how medication works, doesn't work for them, they stop taking it. In my conversation with older patients, they show up with this. They're like, oh, by the way, I'm not taking this. How long are you not taking this? So I'm honing on when somebody says, I'm not taking this or that, even if it's not related to my work medication, even if it's not mental health related, I'm asking them. And then I'm saying, you know what, it's concerning me and I'm okay. Are you okay with me sending a quick note to your primary care physician so they know how to treat you if you don't want it, and maybe addressing it in a different way. But what I found out is that if you take time, me including, take time to explain to the patient why this medication prescribed and how this works, they're more likely to restart their medication, even if this medication is not related to your business. So oftentimes some of my patients stop medication for diabetes. They just stop metformin. And then because they feel that it doesn't work, or because they feel that it makes them eat more, or difficulty sleeping. One of my patients says, when I take metformin, I can't sleep well, so I stop metformin. So oftentimes we sit down and talk about what does this medication do for you? How does it work? And branded metformin is not my area of expertise, but I went and learned how I can explain how it works. If I communicate in simple terms, not medical terms, to the patient how it works, they're more likely to restart this medication. I also communicate to primary care physician, this is what I did, this is what patient said, we'll see the result. Sometimes physicians or psychiatrists prescribing something like a SSRI, which patient knows the prescribing physician will tell him, okay, listen, this medication will take about 30 days to settle in. There are side effects that may come up that will go away after a certain period of time. Your body will adjust to it, and they still will stop. So when the patient comes to me and says, okay, I started Lexapro a week ago, but I felt ABC and I stopped the Lexapro. So then I'm asking them about ABC. I put them on the side. I wrote it down to address later. And then I'm starting to say, do you know how this medication works? And I'm going into details about, okay, the synapses in the brain. This one releases neurotransmitter, one picks it up, like in this case, serotonin. And then I tell them really in detail that medication, so the synapse has only, you guys know the story, the synapse has only a certain amount of time that medication is released and picked up. And if this one is releasing slow and this one picking up fast, or not picking up, or picking up even slower, then after a certain period of time, all of the serotonin that is your brain producing, your body's producing, and it's not used, it's dumped in the ether, in the gray matter. And you need it. To feel good, you need it. So what medication does, it keeps this in the synapse for a longer time, so you can use all of your produced serotonin. Oh, okay, I'll take it. Do you guys hear that often? Or not often? All right, so these are my observations. What kind of questions do you guys have? None? I'm good?
Well, Alex, I appreciate some of the really important points you've made. And as I was sitting here kind of listening to some of this, a lot of this resonates with me. Just some of the points you make about uh, maybe not fully understanding why certain medications are important. Also, too, one of the things I experience, and I'm not sure if other people on this call do too, is many of the geriatric patients I work with are at a phase in life where they're like, I never really expected to kind of be at this point. I had no idea that life was going to be like this for me. And I think that's such a tough thing in the room to kind of sit with because it's a big kind of existential question, especially when things are changing around them so frequently. The passing of friends and family, and sometimes outliving folks that they did not expect to outlive.
Mhm.
And so there's just kind of tough conversations and thoughts that come up with that. But yeah, that's something that finds its way into a lot of the work I do as well. And, I'd love to kind of maybe open that up a little more too, because I like to think I'm not the only one.
You're right, you're not the only one. I'm experiencing these questions a lot too. And sometimes sitting in the room and thinking, what does it mean? How does it affect loneliness? How does it affect my life overall? And oftentimes bringing to this, like you mentioned, existential issue. What is the point of living? What is my living about? What am I doing here? So oftentimes, yes, it leads there. Unfortunately, in my setting, I don't know about you guys, in my setting, I am not able to go into lengthy, like 1 year of services. So I'm topped at 12 appointments. So I have to do the best with providing them with tools now and maybe leading them to literature. Oftentimes, older people like to read. So leading them to literature to read to develop their knowledge or understanding about life in general. Oftentimes, sending them to Yalom's books, variety of them. Yeah. So how would I approach such a question is just exactly like I said, asking about the meaning for them and asking them about their perception of life and relating their sometimes despair to acknowledging it, but then look at what what their life was about and maybe finding positives in life, not only negatives that led to despair. And while you're sitting here today, you have all this life experience. So this life experience, including positive and negative, is affecting of who you are today and how you see the life. And then trying to navigate through the dark thoughts into the light thoughts via existential approach.
I see a question in the chat. This is thank you so much, Dr. Lanious. I have a question. Any tips on how to help older adults be more open to psychotherapy, especially those from cultures where mental health is stigmatized? It was nice to hear that older adults do prefer psychotherapy versus medication.
Thank you for this question, Desiree. It's a very important question, frequently neglected, how to bring older adults to psychotherapy. I usually talk to them about not necessarily presenting it as a psychotherapy. My first word is counseling. So what are you going to counsel me about when I'm speaking with people who are much older than me? Oh, I'm not necessarily going to counsel you. Maybe we'll have a conversation about where are you in life. Maybe I know something, maybe you know something, maybe you can teach me something. I'm open to learn. If you have time for it, are you very busy? No, I have all kinds of time. Okay, so maybe we can meet a few times and see if it goes somewhere helpful. It's good, helpful for you, first of all, but maybe also helpful for me. And then if it doesn't go anywhere, we don't have to continue. You, at any time, you're free to say, stop, I don't need it anymore. And if you're willing to try to see how it's gonna go, I'm all game. So I'm trying to make it easy, Desiree, to answer your question. I'm trying to make it easy decision that it's not I'm buying into I have to show up. As easy as possible. Okay, I see the chat going on. Uh-huh. Geriatric anxiety scale. You know, I only know about GAT-7. I don't know about geriatric anxiety scale. Who said that? Corey. Can you share
Yeah,
that?
yeah, I can like send a link for it. Basically, the reason why I'm interested in that is there's some programmatic developments we're doing at my site where we're trying to find our way more into some of the geriatric care visits within the family medicine clinic. And part of that is within our efforts having appropriate universal screening with instruments that are also a little more appropriate, that the scores won't be super high and inflated because of a lot of the questions that ask about things that resemble physical symptoms. And so, yeah, the geriatric anxiety scale was one that I've been looking a little bit into. So I'll link it in the chat.
Wonderful. So geriatric anxiety scale is unfortunately unavailable in my system, but I'm thinking paper pencil is workable as well. Thank you for sharing it. Andy is asking the same question that Desiree asked about how to lure older adults into psychotherapy, especially from different cultures where it's stigmatized, which I didn't address. I'm so sorry. I addressed how to lure them, but so when I live and work in San Diego next to the Mexican border. I have a lot of Mexican patients and Mexican origin. And when they are talking about their issues with primary care physicians, and primary care physician ask me to come and counsel them, oftentimes we're talking about, well, it's something that I never done, nobody done in my community, in my family, and I don't know how to do it. So one of the questions is, it's inappropriate for my community or for my family. And another question is, I don't know how to do it. So I'm addressing real questions. So if it's stigmatized, I'm going to ask, in which way is it a no-no? Is it a stigma? In which way? What is the problem with that? How do you see the problem? I see the problem because I don't know what to talk about, or I see the problem because my family will not support it. And then we address exactly that issue. So if your family is not going to support you seeing a therapist, do you live with your family? Do they have to drive you? Any other way you can get to the therapy? Um, and any other way we can address this issue, not necessarily including your family in assisting you. Does it make sense? Maybe you have friends and such. Oh, I don't need to tell you guys. If they're talking about, I personally, because I never experienced that, I personally don't believe it's going to be helpful. I said that's your prerogative, of course, but how do you know if you don't try? So I'm just engaging in conversation about it in whichever way possible for me.
Thank you so much.
Of course. Corey sent our geriatric anxiety scale in the chart if you guys interested. Term psychotherapy, I would be mindful of term psychotherapy within the PCBH is not aligned. Yes, I would agree. That's why I use counseling most of the time. But I'm also using therapy word. I typically don't have issues engaging geriatric patients because we are mindful of terms of conditions and PCBH approach and care. Absolutely, I agree. Thank you, Stacy. Okay, so we kind of talked about in general. I try to do this. I try to collaborate, combine research that I found on geriatric primary care and behavioral health as concise as possible. I'm having difficulties find my English words today. As concise as possible. If there are any more questions about any of these things that we talked about, please ask. Okay. We're good?
So Alex, there's actually another question in the chat.
Out of loneliness, patient ask for ongoing sessions. Do you have a favorite approach? Yes, I'm referring in my setting. We have group therapy, and we also referring to community support for ongoing settings. Oftentimes during the first appointment, I'm talking about we have a limit of 12 appointments maximum. We can do less, but maximum 12. If we're starting this therapy and you find that you will need a longer therapy, I don't have a problem referring you to longer therapy in the community now, or do you want to start here and see how it goes? Most of the people say, I want to start here and see how it goes. I had about two patients who said, yeah, please refer me to long-term care so I don't have to switch the therapist in the middle. But we do practice talking about it in the beginning, then closer to the end of therapy, short-term therapy, would you like to continue ongoing support? First of all, we're setting the goal for treatment. Did we meet your goal? So that helps to end treatment, short-term treatment here. And then if you have different goals to address, I would refer you to the long-term therapy. I also frequently refer people to the groups. We have several groups that we provide now in our setting. We have a stress management group. Usually, majority of the people who attend stress management group are older adults. Then we have better sleep group, which focuses on CBTI, of course. And then we have what do we have? We have ADHD group that we just started offering. We have a caregiver support group, which is, we think it's crucial to have this group in our setting. And we have improving relationships. So honing on the fourth part of DBT is interpersonal effectiveness skills. So Corey asked some kind of question. Senior center is sometimes built into plan. Yes, yes, absolutely. Whatever your community where you live, whatever your community can offer, it's really good resources. If you have patients who are care for patients with dementia or patients with dementia, so there nationwide association for dementia. I think it's Alzheimer's. Alzheimer's oriented, but they working with all the dementias, and they have groups for patients with dementia. They have groups for support people, and it's shown to be very, very effective. We have more success with, I don't see what with. With that, okay. This tends to be successful. Okay, there is a good amount of emerging research on social prescribing to manage social isolation. Absolutely. I oftentimes bring that very commonly known research about blue zones, and I'm honing on those with geriatric patients a lot, honing on those blue zone findings, that things that are more important in our health, for our emotional and physical being as we age, and is physical movement every day, diet, sleep, and social support. And if we're focusing on those, how do I get more social support? Oftentimes, my patients starting to go to YMCA just because they started therapy and they finding it helpful. Good amount of merging. Okay, so what does it say? Just publish article. I appreciate Western medicine applied for this. Okay. Stacy, share the link, please. All right. All right. So you guys, thank you so much for being a wonderful audience and participating so actively in this presentation. I don't know, I hope that some of this information was helpful for you. And I'm guessing we're all, including me, looking forward to the next presentation, whoever different, thank you for clapping, whoever will be different presenter for us. I think it's pediatric care. I don't remember. I looked it up a long time ago. So thank you, everybody.
Thank you, Alex. Appreciate the great presentation and the kind of thoughtful intentionality put into this. I think there's just been such a paucity of research and evaluations looking at geriatric and integrated behavioral health care, and I'm glad that it's becoming more of a focal point for discussion with folks. So thank you for the presentation today. One other thing we were going to add to the presentation today is we're just going to talk briefly about a poll we had put out previously. Our SIG group this year, we're really trying to get a sense of what folks have an interest in. A big part of that is year to year. I think there's some converging themes as to what people would like to have as far as discussions and lectures on. And we kind of just had the idea is like, let's just flat out ask and see what folks say, hey, I'd like to have some more focused discussions on. This was one of these topics. And so this was, I think, a lovely timing of the survey results and just our good fortune of being able to tap into your knowledge and expertise, Alex. Several of the other areas that we'll just share really quickly. So looking through what I have in the background here, strategies for developing high proficiency PCBH programs, workforce development and reducing burnout, clinical practice strategies, addressing practical barriers to PCBH implementation, the development of clinical pathways within PCBH settings, strategies for completing research and evaluating meaningful outcomes, and then the PCBH model is applied in specialty and clinical settings. In addition, there also was a lot of importance stressed about trying our best to address historical trauma, discrimination, and culturally responsive care, and structural and systemic inequities. And so with that said, we're really going to try our best to hit on some of these different factors throughout our upcoming conversations we're going to have each month. And each of us is taking kind of a piece of this and running with it a little bit. So Alex focused on geriatric care. The next conversation we'll have to double check on, but it's really going to continue to kind of tap into some of these requests. And we're hoping to continue to use this time intentionally to meet some of these requests and interests in information just to really benefit members of the SIG group. So wanted to kind of put that out there and just share some of that, and that's some of our focus. You take a look at the chat here. Other than that, we do want to thank you all for attending today, our first SIG talk. So thank you, Alex, for graciously stepping up to speak on that. And we have the link from Stacy. Thank you, Stacy. If you have any other questions or thoughts or concerns about anything, please feel free to drop them in the chat. Otherwise, thank you all for attending today.
Awesome. Thank you so much. Bye-bye, guys.
All right, thank you.
Bye. Have a great week.